Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Welcome. Thank you so much for joining me. Today is Monday, May 22nd. We are coming to you live from ATS in Washington, D.C. I'm Dr. Vijay Balasubramanian, and I'll be reviewing some key pulmonary hypertension highlights from Sunday and Monday sessions. The first one I would like to cover is data from the FAR registry, the Pulmonary Hypertension Association registry. This abstract looks at medication non-adherence and clinical outcomes in PAH. There were approximately 1,500 participants. Most patients had PAH and about 13% had CTEPH. The overall rate of self-reported non-adherence was 6.1%. Predictors of non-adherence included male sex, poverty, having Medicaid or no health insurance. Non-adherence was associated with increased number of emergency room visits, hospital visits, and hospitalizations. Non-adherence was also associated with worse self-reported physical functioning and more limitations in patients' daily lives. Given these findings, further research is needed to remove barriers and optimize medication adherence in PAH patients. The next study I want to discuss is the Tory study with seralutinib. Seralutinib inhibits platelet-derived growth factor receptor, colony-stimulating factor 1R, and c-KIT, thereby modulating key signaling pathways involved in pathological remodeling in pulmonary arterial hypertension. In addition, seralutinib can result in an increase in BMPR2, which results in anti-proliferative effects. The Tory study was a phase 2 randomized double-blind placebo-controlled multicenter study to evaluate the efficacy and safety of inhaled seralutinib in PAH over 24 weeks. In the overall population, the mean difference of PVR from the baseline to week 24 was minus 96 dynes per second, which was statistically significant at a p-value of 0.031, a 14.3% reduction. Thus, Tory met its primary endpoint of reduction in PVR. Seralutinib treatment resulted in a significant reduction in NT-proBNP versus placebo at week 12 and week 24. The NT-proBNP trended higher in the placebo group while it was falling in the seralutinib group. Slightly more adverse effects and discontinuations were observed in the seralutinib group than in the placebo group. The majority of adverse effects were characterized as mild to moderate in severity by investigators. As expected with a dry powder inhaler, cough was the most frequent adverse effect. Only one patient discontinued due to severe cough. The next study is a novel win ratio analysis of the FREEDOM-EV trial. FREEDOM-EV demonstrated that oral treprostinil as early combination therapy reduced the risk of clinical worsening by 25% in patients on background monotherapy. Win ratio is a hierarchical statistical approach that prioritizes more important clinical outcomes in composite endpoint trials, which often assign equal weight to death and disease progression. To my knowledge, this has not been previously tested in an event-driven pulmonary arterial hypertension study. The authors, including myself, ranked events from the most to least important as death, number of PH-related hospitalizations, time to the first PH-related hospitalization, time to the first clinical or disease progression event, or initiation of inhaled or infused prostacyclin, and time to the first unsatisfactory long-term clinical response. All possible combinations of pairs were considered without adjustment for the previously reported difference in the risk for death between the groups which favored placebo at baseline. For each pair, the winner is whomever did not have a death or survived longer if both died. If neither patient won by death, then the winner is whomever did not have a PH-related hospitalization or had a fewer PH-related hospitalizations, and so on, continuing through the event hierarchy. The win ratio is the number of winners in the treprostinil arm divided by the winners in the placebo arm. The study had 690 patients, approximately 340 patients in each arm. There were 35 deaths, 17 in the tree arm and 18 in the placebo arm. 98 PH-related hospitalizations, 46 in the tree arm and 52 in the placebo arm. 77 had a disease progression or initiation of inhaled or infused prostacyclin events, with 21 in the tree arm and 56 in the placebo arm. 41 had unsatisfactory long-term clinical responses, with 20 in the tree arm and 21 in the placebo arm. Tree was superior to placebo in a Win analysis based on hierarchical stratification of meaningful outcomes. This analysis prioritizes more clinically relevant clinical worsening ahead of less clinically important events, regardless of when the first composite clinical worsening occurred. The Win ratio approach could be an important way to assess composite endpoints in PAH studies. Next, I'm going to discuss the Expedite study, which answered the question, does a short course of parenteral treprostinil allow patients to achieve higher doses of oral treprostinil compared to de novo initiations without parenteral induction? Expedite was a phase 4 multi-center open-label 16-week study of parenteral treprostinil induction followed by oral treprostinil optimization in patients with PAH. The Expedite trial represents a framework to get carefully selected PAH patients on clinically impactful oral doses of treprostinil in a safe and more timely manner. At week 16, the mean oral treprostinil total daily dose was 16.4 milligrams, with approximately 80% of subjects achieving the primary endpoint. I'm so pleased with how patients did with this approach, as it really did expedite, pun intended, their path to achieving increased prostacyclin dosages. Therefore, the conclusions from the study: Expedite is a useful approach to reach a clinically efficacious oral treprostinil dose. Patients achieved over twice the oral treprostinil total daily dose at week 16 compared to de novo start. The Expedite approach led to low risk status in most patients at week 16. Patients had statistically significant improvements in 6-minute walk distance, NT-proBNP, and WHO functional class. Right heart imaging, Bogue dyspnea score, and quality of life improvements were also noted at week 16. The last session I want to highlight is the clinical year in review. Dr. Gustavo Hiresi from Cleveland Clinic in Ohio presented 5 publications, including the New European Guidelines, the Stellar study on sotatercept, the first clinical report in PVDomics, the FOCUS trial, and the RACE trial. I'm going to discuss the RACE trial, as this was important as it provided some guidance on multimodal therapy in patients with inoperable chronic thromboembolic pulmonary hypertension, or CTEPH. RACE study was done to compare first-line BPA versus first-line riociguat in inoperable newly diagnosed patients with CTEPH. 36 out of 53 patients received initial riociguat followed by BPA, and 18 out of 52 patients received initial BPA followed by riociguat. Both groups achieved similar reductions in PVR at 52 weeks. However, there were more serious adverse events with BPA first line versus riociguat first line, suggesting that riociguat may be better given first line followed by BPA. I hope you agree that there have been some exciting studies presented at ATS 2023. Please join me again on Wednesday, May 24th, when I will be presenting additional studies from the Tuesday and Wednesday sessions.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and click on the Claim Credit button associated with today's clinical clip.